We move voluntarily to feel good, we move to get stronger, we move for peace of mind, and some of us move involuntarily, repeatedly. Hello and welcome to TickFit the podcast, a podcast where we discuss all things movement in both the exercise sphere and in life with Tourette syndrome. This is a platform to discuss Tourette syndrome and its effects on our bodies. We'll speak with movement professionals where we can advocate and educate about Tourette syndrome, while the Tourette community can benefit from the expertise of these individuals. We'll also speak with professionals about Tourette syndrome and other tic disorders. I'm your host, Raquel Cunningham, and I've been on a quest for the past 2 decades to discover the connection between movement, exercise, and our ticking muscles. This is not meant to diagnose or treat Tourette syndrome. There is no cure for Tourette syndrome. We are here to advocate and educate about Tourette through conversation, and anything in this podcast is for informational purposes only. Please always consult with your doctor before beginning any exercise program to make sure that it's right for you.
Hey, welcome everybody. I am super excited today. Our guest is Dr. Kevin Black. He is a movement disorders neuropsychiatrist based out of Washington University in St. Louis. He's been studying Tourette syndrome for the past 30 years. We are incredibly excited to have him here. Welcome.
Well, thank you. I'm glad to be here.
Awesome. And if you are watching this instead of just listening to it, you might notice that the background has changed. We've taken TickFit the podcast on the road. My internet went out, and luckily my dad lives close by. And so here I am in his office, and serendipitously, he has a brain in the back that we might be able to use for any discussions. But so here we go. But so Dr. Black, you have been studying Tourette syndrome for 30 years. What have you seen change in research over that length of time?
Oh, that's a beautiful question. I guess the biggest changes probably relate to people finally discovering the benefits of behavior therapy for tics and turning that into really solid, rigorous research. And also a greater internationalization of research on Tourette. I think when I started, there were people in various places around the world doing good stuff, but I think the majority of really interesting study was happening in the States, and maybe that's because I live here, but maybe 15 years ago, thereabouts, a lot of tic doctors and scientists got together in Europe and decided, well, like in our small town here, we're only going to ever have our 23 tic patients, but if we get together with other places in Italy, let's say, then we'd have hundreds of patients. And then if we join with Germany and the UK or whatever, then we'd start being able to do really good research. And so, a lot of, I'm sure, negotiation and beating down of ego, went into making that work, and they did it, and they've put together some really very exciting research from Europe that I think has made a difference.
Right. So it's really becoming more understood, studied, and researched on a global level.
Yes. And then there's also, as you may know, the TTAG. I can't remember what it stands for, but it means tic societies from around the globe, basically, starting to get together so that there's a little more, natural access to resources and other people from lots of other countries.
Yeah, I actually have encountered people from different parts of the world that are traveling either to the States or to Europe to seek help.
Yeah.
And yeah, it's largely in part because of organizations like that are making resources more available.
Yeah. I could say a word more about that behavior therapy if you'd be interested.
Very much so.
So when I started, my career, basically, there had been a few publications, mostly from one psychologist and colleagues, that really suggested they had this dramatically beneficial treatment for tics. And, in medicine, like a lot of things in life, everything works at first, until you find out when it doesn't work or whatever. And so, there was a little skepticism. But I think a big part of the problem was that physicians mostly don't read psychology literature and vice versa. So things written by psychologists would say things like, well, you could give somebody medicine, but oh my goodness, why would you want to give somebody medicine that has side effects? And then things from doctors would be like, well, like you could do some kind of psychology thing, but a lot of these people aren't weird. And like, why would talking about your mother help with your tics or whatever, both sides showing they really didn't understand what was going on the other side,
Interesting.
And, and then thanks to a couple of psychologists who were willing to talk to neurologists and psychiatrists and the other way around, the communication got better, I think, and people understood a little better what was going on. And so two of the largest and best controlled research studies of a treatment happened with behavior therapy. And this was one large study in children and one with adult patients with Tourette syndrome, and really clearly showed that the specific kinds of behavior therapy that they were testing was much better than kind of generically being supportive and talking to people for the similar amount of time. It wasn't just that there was somebody to hang out with and be a pretend friend or whatever. It was actually doing the specific assignments between sessions and stuff like that. And that has proved to be respected to the point that the American Academy of Neurology, a couple of years ago, when they came out with their review of the treatment literature and their guidelines for treating Tourette syndrome, the first recommendation for active treatment after education and assessment was for CBIT, or comprehensive behavioral interventions for tics, one of the kinds of behavior therapy that's been best tested. And so that's a huge change in how physicians were approaching tics, I think, and fits well with other kinds of therapies like physical therapy or activity training or occupational therapy, because it's from this standpoint of, okay, whether or not we're curing something, we can make a huge difference in somebody's life and actually directly treat some of the symptoms. So
I get it. Here's this multidisciplinary approach to, a very complex neurological condition. So let's backtrack for a minute here. If we were to kind of speak to, trainers and coaches and movement professionals first, before we get into deeper underpinnings of what's going on in the brain, if somebody heard that someone has Tourette syndrome or Parkinson's or, Huntington's disease, I know you work with that as well. On the exterior, if that's all you know about that person and have limited knowledge, like what might that look like? And I know there's different manifestations, but
so let's say you're a trainer and you meet somebody with Tourette's and you don't have much experience with it at this point. Yeah. Well, anybody listening who has tics probably knows the answer. People have all seen one or two episodes of some TV show or other that had somebody with Tourette's, and like one of my friends and colleagues, John Meek, who was head of child neurology at Rochester for a long time. What he said, in real life, maybe 10 to 30% of people with tics have coprolalia, but on TV, it's 100%. And his point was that what people know from society around them isn't really very representative. And it doesn't give you a sense of, oh, this is treatable, what you see in typical cultural representations, I think. And to some extent, that's the same with any condition. It gets in the news when it's really bad, or when somebody has a bad social consequence of it, or like somebody, they won't let somebody on the train because they have seizures, or, I don't know, whatever, make it up. But you know what it's like it's, you don't see the typical person in a movie, because then it wouldn't be a funny movie or something, or
then it's
whatever.
not cinematic.
Yeah. But our lives, unfortunately, mostly aren't cinematic, but
very true.
Yeah. But yeah, so I think that's, I suspect that's that you wouldn't get a sense of, oh, this is somebody I maybe could provide some help to.
Some kind of movement support, right?
Yeah.
To address the repetitive nature of, a physical tic or a motor tic or a tremor, something like that. But
interestingly, there's a way that kind of ties back into the beginnings of the behavior therapy, which is that the original thought behind habit reversal therapy, which is kind of one of the core parts of CBIT, was that, like, if, let's say, you have a tic where you're always like hitting your opposite shoulder with your hand or something, then they're like, well, you're using that biceps too much, so let's make your triceps stronger and let's, push. Let's practice when you're about to tic. Instead, you're going to push and strengthen that triceps, Well, it turns out that's probably not how it works or anything, but at least, somebody was thinking along those lines very early on, like, let's try to balance out your what you're training a little bit more.
Yeah, your musculoskeletal system at that point.
Yeah.
I find the physiology of tics fascinating. Somebody described them as non-purposeful movements. In the fitness world, there's been a huge push for functional movement training, and tics are non-functional. It's a hit, it's an elbow, it's not a mechanically sound movement.
So you mean that in a different way than I was thinking, like it isn't that it isn't what you want to do, or it's not accomplishing a goal of yours. It's that it's not a good, healthy movement is what you're pointing out.
I think that's extrapolated from that very idea, actually. I think when you find balance to a muscle, so like reciprocal inhibition, that would be the bicep tricep analogy that you just spoke of, but how can you plug that into the rest of the body?
Yeah.
Right. And, tics are complex, and there's a sensory component to it with the premonitory urge that I think we can grow that initial idea of, okay, the biceps working, let's make the tricep work. I think you can grow that to the rest of the system of the body.
Yeah.
And then from there, do you, dive into a parasympathetic response that maybe downshifts the body? I've come across a handful of studies looking at sympathetic arousal versus sympathetic versus, deep breath work that encourages parasympathetic state. So I find the physiology of them fascinating, and then how that applies to what's going on in the brain as well.
Yeah.
Big thoughts.
I mean, we don't know enough probably about how environmental factors that modulate tic frequency and occurrence work. I mean, we're learning some of it, but what I mean is everybody with tics knows that, like, tics might be worse, when you get home than they were at school, or maybe they're a lot better when you're running than when you're sitting at home, especially if you're not running away from somebody.
Right. That's a different. That's a chase versus a choice.
And tics are, for many. So one of the strongest is when you're performing music. Tics tend to be at a, close to at a minimum compared even to listening to music that you like or whatever. So there's all these factors where, well, I do this thing and my tics get better, and they're not the same for everybody, but there's a lot of overlap among people too. So why is that? Is it you can't explain it all with distraction, and you can't some people enjoy running more than others. That's probably not the explanation either. Exactly how is it that works? Some of it, I'm sure, is relaxation and a focus on the rest of your body and mind instead of just the tics, because that's so natural. When you have a tic, everybody looks at you, or you're thinking about not doing it because it's a high stakes situation where you don't really want to tic a lot, or so I'm sure some of it is that distraction and calming and losing that arousal and so on. But I don't know if we know enough about how that works. Why is it that tics are so much better during sleep?
I don't think we know enough. And I love asking the questions that maybe we can find out more whys.
Yeah.
Is it, between running and playing music, like both of them have a breath component. That's
Mm,
usually what I always divert back to. There's something about the diaphragm and like the musculature of the diaphragm working,
mm,
um, and parasympathetic state. Your diaphragm is largely responsible for um, parasympathetic work, and sympathetic, depending on what your experience is at that moment. But so far, every conversation, every interaction, every time I've worked with somebody with Tourette has just encouraged pursuit of this. It's never led to an answer, but it's continue asking, continue looking.
yeah. Well, and as a scientific community, I think we're very slowly, much too slowly, probably. Somebody told me in medical school, when all else fails, listen to the patient, right? And
Right.
I think gradually we're doing like slightly better at listening to the community of people with tics, and not always agreeing, but that's okay, because as
Absolutely.
long as you're having friendly chat, you can get through that, But for instance, some journals strongly encourage or even require you to involve patients in at least commenting on the study, but optimally in planning the studies or in, making sure that interests of patients are watched for in a way that might be specific to this population or, and I think as one example, I remember some years ago going to a meeting where um, somebody with lived experience with tics was talking about how frequently pain was associated with tics. And I thought, what does pain have to do with tics? I mean, like occasionally, yeah, but it turns out it's a rather common accompaniment of tics, and not just from self-injurious tics or, banging your elbow on a wall or whatever, but from kind of constantly ticking, for instance. And, so there's an example of where, we were made to listen, but we listened, and that's a little more attention is turned to that. And anyway,
Yeah, I agree. I think the again, going back to kind of the fascination of the physiology of tics, a tick itself might not hurt. An eye blink doesn't hurt. When I would twist my neck, that wouldn't hurt. But if I do that 40 times, the repetitive
yeah,
nature of that non-purposeful, non-functional movement has wear and tear,
well, sure, yeah,
right?
yeah,
Even an eye
absolutely,
blink, like an eye strain, eye blinking being a huge common tick, was one of mine
sure.
for 20 years. To have to strain your eye I don't even want to do it because I don't want them to come back. But
No, right. I
it's
mean, if you were,
painful.
I mean, you go to the gym and you lift weights, you expect to hurt, right? I mean, maybe I
Right.
shouldn't, but like that's what I expect, And
Right.
and so if you're doing, some violent movement, 100 times a day, I mean, of course it's going to cause some problems there. So, right. So,
Right. Just my question largely is this, and this is, unanswerable at this time, but maybe in 15, 20 years, hopefully sooner. But to what extent, and we'll get all wordy and fancy here, but to what extent can neuroplasticity driven by voluntary movements help with neurological conditions?
huh.
Like to what extent? And it's going to be different for everybody. Is it by centrating joints? Is it about by the type of exercise? Is it
Yeah. So when I hear those words, you can tell me if I'm getting it right, but I'm thinking of things like, um, exercise, like physical therapy, like, and even to some extent, like um, the kind of contrasting movements were that are part of habit reversal, but maybe that's not what you mean. I should probably check my English here.
no, again, that's why I love these conversations. It's to so something like a high intensity workout
Uh,
to me might trigger somebody tics, if they know when they play video games, that increases their tics because that has that same reactive stimuli.
I see.
Versus something like yoga, which actually increases my tics because you're told to be quiet, you're told to be calm and patient. So to find these different avenues of reactionary training, being a good or poor fit for somebody, yoga being a good or poor fit, and then the whole world of lifting, which, gazillion movement choices within there, that we could fine tune and pick movements that might adapt to that person's goals and competing responses.
It makes sense to me that something along that direction would work well. But other than the competing responses as part of habit reversal, I don't know that we've proven what works well and for which people like you bring up. And, I suspect that there will be some kind of, precision medicine or individualized treatment that'll go into that, just like, as you pointed out, like some people, some kinds of exercise helps and other people it doesn't. So here's one example. You may have heard of the median nerve stimulation for tics that folks in Nottingham, England were the first to test, and we did a little testing here in St. Louis.
Have heard of it, but don't know that much about it. Can you explain what that is?
So the idea was in the part of your gray matter that is most closely tied to movement, there are certain average brain rhythms that seem to be associated with more or less movement. So certain frequencies of repeated signals in the cortex that seem to go with less movement. And so Stephen Jackson is the researcher there who was thinking, what if we could kind of talk your brain into having more activity at that frequency range rather than at other frequency ranges? Maybe that would slow down unwanted movements. And so what they did is, and they had noticed that there was some research that for other purposes had shown that if you stimulated a peripheral sensory nerve, that the other side of the brain would tend to copy that frequency range somewhat. And so they're like, well, let's get the simplest kind of stimulation we can that people have done for ages, and so we don't have to worry as much about safety testing. And so they just stuck a couple of wires here on the inside of your wrist, the same nerve that gets involved with carpal tunnel syndrome or whatever. So a lot of people know what we're talking about, kind of. It's a median nerve because it's in the middle of your wrist. And you stimulate that at 10 to 12 pulses per second. And if you do it enough, then if you very, very gradually turn up the current, first you don't notice anything, and then you start noticing twitching or tingling feelings, and then the muscles that are connected to that nerve start being activated because they're also, movement nerves there. And so like you start twitching the thumb, for instance, like this. And which is kind of a weird feeling because it's completely not related to your normal mood. It's not voluntary in any way, so it feels weird when you look and you see your thumb twitching. But anyway, first of all, they demonstrated that this would induce more activity in the contralateral motor cortex at that particular frequency range. Whatever frequency they were stimulating at, your brain started echoing that to some extent. And they showed that a couple of different ways using different technology. And then they had, I don't remember exactly, but something like 30 patients come in with Tourette syndrome. And during the stimulation and for a period after, people reported their tics being better. In a few people, somewhat dramatically better. In others, not so much, whatever. And so then we both separately, but talking to each other, did controlled trials. Ours was a smaller one where we were focusing on the period of time where you're sitting right there in front of us. And we had 2 different kinds of stimulation, one of which was supposed to be a placebo stimulation, because we knew from their work that it didn't do the same thing to the frequency on the other side of your brain. And they did a much larger study that looked both at your tics while they were doing that stimulation, but also over the week, over the rest of the, so the stimulation only took like 14 minutes a day in their study. But then they were asking you, how are your tics in general, like over the past week, even though you're doing this, just in the mornings or whatever. And they had a different control that was well chosen, and they were able to show that the active form was much better than the inactive form at controlling your tics, even not just during the sessions, but during the rest of the week. So that's pretty dang cool.
Yeah.
They're trying to they've built like a kind of a fat smartwatch shape type thing that its purpose is just to give you zaps on the inside of your wrist at that predetermined frequency, for a few minutes here or there or whatever. You can turn it off, you can turn it on, like you hit the button or, and it turns on, and you turn it off or whatever. We used an over-the-counter TENS unit, which people here have used for back pain or whatever, for other purposes. And so, but to turn it into a new device and then to sell it and say this helps with tics, that's a huge humongous amount of paperwork, because then the FDA wants to be very clear that you're not just, snake oil salesman or whatever, and that you're not going to hurt people, but more that it actually works and everything. And so there's I think strong evidence, but that would be a big journey to make it something you could buy at the store here. Anyway, so my point was, like, here's oh, sorry. So all of that was meant to be this long introduction, but it wasn't supposed to be that long, into saying that when I presented this research at my home institution, somebody said, I do EEG stuff, and it turns out that everybody's, resting brain frequency, their alpha frequency, it tends to be at slightly different frequencies. One person's more 6 or 8 or whatever it is.
Interesting.
And so what if you kind of tune it to people's background frequency, like, rather than just everybody being at the same number? Wouldn't that be interesting? Well, so it would. I don't know if that would make a difference, but the point is, there, you could imagine ways just with that one treatment that you would be trying to tune it to that one person. Right. And I bet there's lots of kinds of sensory or movement feedback that you would be needing to tune to a particular person. And I don't think really know how yet. Because what works right now when you try it. So like one of the things you find when you're doing behavior therapy is you explain it to people and they're like, no way, like I'm already all day long trying to suppress my tics here and there. And you're like, yeah, but bear with me for a second. Like, you're doing that on the fly, and at the moments when it matters the most. That's not how you do training. That's like, I climb stairs when I have to,
Right.
Yeah. So what we're doing here is you try to do with every tic for a period of time, or with a given tic every time it happens for a period of time, depending on what kind of therapy you're doing. And then it turns out that we've tested this and it works, and people are skeptical because they're like, well, when I try to suppress my tics for an hour-long meeting and I come out and I go in the bathroom and I'm just ticking like crazy for 15 minutes, and that's not helping. I'm like, I get it, but that's if you're only doing it part-time. And so I imagine that the same thing might apply to any kind of physical intervention, that what works for a minute may not be the same thing that works for all day long, because it might be successful, but kind of building up the urge to tic, for instance, is something we wouldn't want to do.
Right.
Yeah.
as you bring up the vibration through here, I just had a conversation with someone the other day whose son has tics, and he found such comfort and management in drumming music and rhythm, and actually made something that you put on your wrist and will vibrate as if you're drumming for something that you can take out into the world if you don't have your drums there. But it's fascinating that it's on the wrist too, with that vibration, exactly as you just described with the electrical impulses there.
Yeah. No, I could imagine that. And I think if I don't know if they went forward with it, but one of Dr. Jackson's collaborators was interested in applying vibration there instead of electrical impulses, just to see if it would work the same way, which it probably would. But yeah, no, that's interesting.
Right? It's when these parallels happen, I don't do research, but I connect dots, and sometimes there's a reason that they connect, sometimes not. Yeah. But I'm here to point out, like,
And congratulations to your drummer. I'm used to drummers like from high school that like were always drumming no matter where they were. So, trying to make it less, intrusive is a win.
We got our kids a drum kit, and I freely hand out earplugs when people come over. Here, this is where they are. If you need more, please help yourself. There's so much when it comes to the brain. So you're speaking of, the gray matter and where the motor cortex is. We do know, not we, but I've read that you guys know that the basal ganglia is, highly involved with Tourette's. How is that? So what do we know of that so far?
Oh boy.
Yeah.
So that's a lot of information. Wow.
Too much on that?
That's going to take me a second. I guess the short answer is one of the easiest things to measure in non-human animals is how they move, because they won't talk to you.
Right. If they do, that's a different situation.
Yeah. And so a lot more research really has gone into how is movement controlled in the brain than a lot of other things. And so we know increasingly more about how circuits that are clearly involved in simple movements relate to other very similar circuits in slightly different parts of the brain. So, for instance, you can track out several different circuits that all pass through the basal ganglia, but on average, slightly different parts of the basal ganglia. And the one that is just apparently related to kind of simple movements, like I'm going to twitch my finger or something, connect gradually to more kind of conceptually distant parts of the brain, like that deal with processing emotions and reacting to them, or that deal with that are involved with things like OCD, or that are involved with remembering negative situations in the past, or whatever. So that's just on an anatomy level of knowing how that all fits together that way. And then there's to some extent that old saying about, like, there's the drunk guy on the street that's looking for his keys under the light, and somebody says, well, you've been looking for a while, and he's, where did you drop him? And he said, well, I dropped him over there. And they said, well, why aren't you looking over there? Well, here's where the light is. And to some extent, like, we look where we know how to look for things, and so a lot of research is focused on the basal ganglia because we know it's involved in, for instance, in treating Parkinson's, or in treating dystonia or tremor or other kinds of abnormal movements. And so, well, try that for tics, right? But, everybody with tics kind of knows that they're a little more complex. It doesn't happen all day long equally. And, you might go for minutes and minutes without a tic and then have 12 of them, or like we've been talking about, certain situations seem to stimulate tics or make them better, depending on what's going on. So, and that happens to a lesser extent with some of the other abnormal movements that people can have. So you'd expect it to be a little different in what parts of the brain are doing what. So anyway, that's just me, I guess, giving warnings and biding for time while I try to sound clever. Well, so
you're at the forefront still of what we do know, which is, I mean, it's a very complex disorder, with all of the variables that we can't account for, with all of the movement manifestations that we can't even count because they're infinite. It's a lot to try to make sense of.
I guess I would say one of the strongest pieces of evidence comes from a relatively small number, fortunately, of people who have died and their brains are available for study after death in autopsy studies. And there are certain cell types, inhibitory interneurons. So in other words, nerves that, kind of provide a local brake on activity in that part of the brain in the caudate putamen nucleus accumbens that have died off or that never grew as much in people with tics compared to people without tics.
Interesting.
This is, the kind of research we don't want thousands of people all of a sudden for, because we can't get you to come back after the second, and we don't want people to die. But that is really fascinating. And so it suggests that, maybe it's that kind of cell is really important in keeping tics from happening in everybody, for instance, or in making them usually go away when people have tics as kids, to the point where they're not as much of a problem compared to any adults listening to you where the tics are still a problem. If you have tics for 3 months when you're a kid and then afterwards they're minor enough that nobody notices them, that's not the people coming to the doctor,
Right.
We're, the people who are still having really problematic tics, that's where it kind of in some senses matters the most. And that maybe that's how they're involved in these cells. So people have ways, what we have available to us for ways of looking inside your brain while you're alive are things like MRI for brain structure and functional MRI to look at what parts of the brain are active at different moments compared to, let's say, when you have tics or whatever. And we have things like PET scans that can look at certain kinds of, where are certain chemicals placed in your brain and how much of them do you have versus somebody else.
Okay.
And all of those studies have been done in people with tics, increasingly with more data. So, for instance, I'm part of a study called the Enigma TS group. And Enigma has to do with neuroimaging in like dozens of different centers that didn't collect exactly the same kind of data, but we have ways to try to mush it together and have big groups of hundreds or thousands of people rather than 30 or 40 people.
Okay.
And we're just involved right now in putting together our first publication about what parts of the brain may be smaller or larger in people with tics versus people without tics. So that's going to be really interesting. That's been done before. I was part of one of those bigger studies that's been published previously, but that one had like 103 kids with tics and 103 kids without tics. This new mushing everything together will have more than like 4,000 people in it. So,
wow.
So hopefully we'll be able to, be more confident in the results there. Something exciting in recent year or two is some of my colleagues that I can claim closeness only because their office is like 100 feet away. I mean, I know who they are, but we haven't done much together. I can't claim any credit for any of their work is what I'm saying. But
yes.
But they've determined that the old model that we have of that people have seen a little drawing of a little homunculus or a little miniature person kind of lying across one of the folds of the brain, so that like your hands are a big part of it, and your feet are part of it, and your belly's part of it, your face is a huge part of it. But basically the body was kind of spread all over it. That's not really accurate. That what in fact happens is that there's these intervening zones that are more related, it appears, to like whole body control rather than control of one limb or one body part. And this has been called the scan for a certain kind of network activity. And this is basically what your brain's doing when you're not telling it to do things, when you're just lying there and we watch your brain activity, you know, every second for like half an hour or whatever. Then some parts play along with other parts, or they turn on at the same time. So like, for instance, the part of your brain that is most involved with winking your right eye is on the other side of your head from the part that winks your left eye, but they both tend to activate at the same time many times, you know, and so there's probably something similar about them. This is the idea, roughly.
Interesting.
And so this collaboration between different parts of the brain basically is what these functional connectivity MRI studies try to map out. And it may, there's some evidence already that this scan network, along with another movement network, may be specially involved or different in people with tics versus people without in the way that it functions. It's also, I guess it's worth saying also, one of the nice things about Tourette syndrome is, you know, when you're not, at the moment when you're not ticking, more or less your brain is acting like other people's. Like, you know, you can walk, you can dance, you can swim, you can jump up and down, you can hold still, you know, like anybody else, and you can think and paint and run podcasts and, you know, whatever. You know, so that's great for people with tics. But it makes, in some ways, makes the research a little bit hard. It's not like all day long this muscle is excessively active, or all day long, you know, at any moment that we happen to peek in your brain that there's something going wrong in that area, you know. So it makes the research more, you know, more complex or interesting in that way.
Right. But the fact that the whole like kind of model of the brain is shifting, you know, as new technology comes and new scans and, you know, larger studies, I think it's exciting. I think it's interesting that you bring up, you know, the opposite side. You know, one brain controls the other side of the body. Kind of in the tic world, everybody finds their tic superpower. Mine became like a symmetry tic, I call it. Because if I did a move on one side, it immediately created a premonitory urge to create that same sensation on the other side. It did not matter the amount of repetitions, you know, so if I blinked, or especially like wind on my eyelashes or face hit this, I had to somehow create that same sensation over here. And it was, I wonder what's happening on the crisscross sides of the brain during things like that. But
yeah, no, and actually, lots of people have, lots of people with tics also have, beyond that, have symmetry obsessions and compulsions. You know, like if you touch my one wrist, you have to touch the other one, or it doesn't feel right, that kind of thing.
right.
Everything, you know, somebody the other day was like, okay, I've been sitting here for half an hour, but that one, you know, plaque on the wall that's, you know, the Barnes Jewish Hospital thing is like a little bit crooked and it's driving me nuts. Can I just fix it? You know, which is kind of normal human in a way. Like we all do that a little bit, but yeah, we're not all that bothered by it all the time, you know, so.
Right. How very complex and I don't know, just the uniqueness of how this presents from person to person is, I mean, first of all, what makes us all human, but at the same time, it becomes challenging to offer support and help, especially when tics do affect that person's life.
Yeah.
Do you see people in clinic, or are you mostly involved in the research of, these large studies?
I'm most of the time doing research and or answering emails.
Fun
But
times, that is.
but I do see patients like 1 day a week. So
Okay.
yeah.
What was your initial why Tourette? Why movement disorders? How did
Oh.
you get started in this field?
I mean, honestly, first of all, it's like one of the most interesting things around. I guess looking back, there's probably two major regions. One of them is like people in my family have tics. I actually have tics, but I don't usually talk about it because they've over the years really been so mild that people come in with really bothersome tics. I don't want to sound like, oh, I know exactly what you're feeling, because I don't. I mean, it's a different situation, but that made me interested, of course. And then and another thing I've always been interested in is the relationship between illness in a big sense of the word, like anything that can go wrong with how your brain works or whatever, and culpability for actions. So like, like as one example, one of my patients who's talked about this publicly, I'm not telling tales out of school here or whatever, but like was tells about how he was a tennis player in high school, and he was sitting on the bleachers for a minute watching somebody else play, and he had typical phonic tics, and some of them were kind of loud. And this guy sitting next to him says like, hey, you can't be doing that here, because like my daughter's there serving, and every time you make that noise, it's and he's like, well, I wish, I'm not doing this on purpose. And he had one of those little cards that says like, I have Tourette's, and I'm, he handed it to him. And the guy's like, I don't care why you're doing it. Like, but you're going to interrupt the people playing, And in that situation, I think you can really see both sides there. Like, it's not something he's doing on purpose. It's not like he can stay sitting there watching the game and not make any noise for an hour or two with his current severity of tics, And on the other hand, yeah, it's really going to be bothering people on the court or whatever, So anyway, that's just one example, and tics come into that discussion, I think, in an interesting middle place. It's not like dementia or like delirium, when somebody's kind of sick out of their head because they have bad pneumonia, where like you just don't blame them for anything pretty much. And it's also not like somebody who's just annoying their whole life and that's just their style, It's very, very, very much in the middle of where like, because there's, you have some temporary control over tics, and yet, or at least many tics. And yet, you're not decided. It's not like you set out in the morning and say, okay, I'm going to have tics today. That's not how it is either. It's not really intentional in that sense either. And so, I don't know. It's not like I find great insights in every patient about that, but that's something kind of on the periphery of taking that makes me interested. But
yeah, I mean,
and patients are kind of cool, They're people with tics who come to doctors. Not everybody with tics, but people with tics who their tics are bad enough to come to doctors, usually have 2 or 3 other problems that we can help with. OCD is what, a third of people with tics, maybe ADHD, maybe half of people with tics. Depression's not rare, even if it's not really part of tic disorder. You're living in the world and everything. Other anxiety disorders are really common. So, there's a lot you can try to work on with people and try to help their life. So that's been rewarding.
Well, thank you for helping people's lives. It's a big deal.
Yeah,
it's a big deal to
no, I care about that, but it doesn't always work, and you want to take the credit all the time when it does work, but you have to recognize that you do your best sometimes and it doesn't work, or people don't like what you've done, and so that's all true.
Yeah. I mean, that's true in training too. But Dr. Black, this has been incredibly insightful. Thank you for sharing your brain with our brains. I'm very grateful to learn more about, how research has changed, where we're going with it, and even to ask unanswerable questions right now, in the hope that one day, we might be able to revisit this conversation and see what's come of it.
Yeah, that'd be great.
So thank you very much. I appreciate your time, wisdom, expertise, and your commitment to the TS community.
My pleasure. And thanks, Raquel, for the invitation.
Yeah, thank you.
We love providing a platform for sharing ideas about living with Tourette syndrome and other tic disorders. While we strive to keep the content evidence-based, please understand that exercise science, information about Tourette syndrome, and its co-occurring conditions are constantly evolving. The content shared in this podcast are for informational purposes only and should not be considered medical advice. By listening to this podcast, you agree to not use the information as a substitute for professional medical advice or treatment for yourself or your child. As always, consult your healthcare provider before making any medical decisions or starting any treatments related to Tourette syndrome or other health conditions, which also includes mental health. This disclaimer also applies to any guests or contributors to the podcast. TickFit and the podcast team do not take any responsibility for any actions taken based on the information provided. Our goal is to educate, support, and raise awareness, not to diagnose or treat any medical condition. Thanks for listening.